when the baby's born, you are all excited and you are thinking about who this baby will become. Or so when a baby is sick, it really breaks my heart. I mean, any patient breaks my heart, but especially a baby, because you kind of break that promise that is in the beginning.
Welcome to NICU Heroes, a podcast produced exclusively for NICU professionals, with me, Kathryn Whitaker, as your host. I'm the mom of 6 children, including my very own NICU baby. This podcast is produced by Hand to Hold, a national nonprofit dedicated to providing free personalized support, resources, and community before, during, and after a baby's NICU stay. As a NICU professional, you've been well trained to care for the tiniest and the sickest babies every day. While a NICU parent's scars are not as visible, those parents are often as fragile as their babies, requiring patience, guidance, and encouragement to ensure that they are mentally, emotionally, and physically prepared to endure the pressure of a NICU stay. NICU Heroes is dedicated to helping NICU professionals like you better understand, support, and nurture the entire NICU family. Howdy, y'all. Welcome back to NICU Heroes. So the very beginning of the year, we started off with Dr. Penny and the pediatric heart, and every month we have continued to have exceptional guests. Today is no exception. Dr. Parravicini is my guest today. She is going to be focusing on palliative care for neonates. I mean, palliative care has been around for a very long time, certainly for adults, definitely for pediatrics. But palliative care for neonates has not been around nearly as long, and there are some amazing things happening in how y'all can serve your patients better, how you can be more present to those families, probably on their hardest day, or if not their hardest day, their hardest season. And so I wanted to give you a guest that could give you some hope for what is happening in palliative care, some great resources if your hospital does not currently have a dedicated neonatal palliative care program, things that you should say or should not say. So there is a lot that we cover in today's episode. So I hope that you take some great wisdom and also some great rubrics for how can I serve my patients and my families better, particularly those who are dealing with a patient who either has a life-limiting or a life-threatening condition. So today my guest is Dr. Elvira Parravicini. She is an attending neonatologist at New York Presbyterian Morgan Stanley Children's Hospital, and she is also the director of the Neonatal Comfort Care Program and a professor of pediatrics at Columbia University Medical Center. She obtained a certification in palliative medicine from Harvard University. She was born, raised, and attended medical school in Milan, Italy, and you will hear her lovely accent. And then she moved to the United States in 1994. Her passion for helping the most fragile patients and the neonatal population inspired Dr. Parravicini to create a unique and innovative program for infants affected by life-limiting or life-threatening conditions. The Neonatal Comfort Care Program addresses the complex medical and non-medical needs of infants and their families. The interdisciplinary neonatal comfort care team supports expectant mothers of babies diagnosed with a life-limiting condition during the perinatal journey, from diagnosis to delivery and beyond. And so with that, let's have an amazing conversation. Well, I'm so excited to have Dr. Parravicini here. We've had her before over on our Parent Focus podcast, but today she's over here on NICU Heroes. Dr. P is what I hear people call you at your office, but thank you so much for being here.
No, thank you for inviting me. I'm very excited to spend this time with you and whoever is watching at this.
Well, I really think that this is an important topic, and we're going to talk about the hard parts, but also some of the redeeming and restorative parts of what palliative care is like. But I think I'd like to start from the beginning. I always like to give people a sense of who you are and where you came from and your why. So I know that you studied medicine, but why did you move into neonatology? And then why did you move from neonatology into palliative care? I'm curious about that sort of transgression from moving from medicine all the way to working with patients who have babies who are in life-altering positions.
Sure. Well, I always loved babies. And even during my beginning of studying at the medical school, I had always in mind that I wanted to deal with children, with babies. And even I remember one of my professors told me, with your face, you can only do pediatrics or neonatal. I do remember that was my professor for medicine. And no, so I had this love for babies, because I think at the beginning of life, there is a lot of expectation about the big expectation towards life. When the baby is born, you are all excited and you are thinking about who this baby will become. Or so when a baby is sick, really breaks my heart. I mean, any patient breaks my heart, but especially a baby, because you kind of break that promise that is in the beginning. And so that's why I decided to become a neonatologist.
Well, I think that's a good reason to become a neonatologist. You probably served your patients really well. Dr. P, as you started to really, I think, fall in love with neonatology, I know you started off in Italy and now you're in the States. What what was the moment that you said, I love babies, but I also now want to focus on palliative care, particularly for babies, because I know that there is hospice and palliative care for patients of any age. But why did you choose to focus on first palliative care and then why with neonates?
Sure. So in the very beginning of my career, I had the dream to take care of any baby. And I was sure any baby will go through my hands, will be healed and will be fine. And at that time, working in Italy, I work in was a big hospital for Italy, but small in comparison with what we have here in the United States. And so the occurrence of a baby with a short life was kind of rare. When I moved to the United States and I started working at Columbia University, the number of babies, especially because Columbia University is an academic institution and we have a lot of high risk pregnancy. And as a neonatologist, we work with the families during pregnancy to counsel them about what we can offer when they are expecting a baby with serious conditions. And so the occurrence of babies with the life-limiting condition was much bigger here in the United States. And I realized that, yes, I want to save baby's life, but it sometimes doesn't happen. And so for me, it was very important not to censor this desire of or be willing to save all babies, because this is my desire as a doctor. I cannot just put it away. And so I was thinking, how can I save their lives? And so the idea was, well, life is given. I don't decide at the beginning and the end. As a doctor, I can work hard to save their life. In these cases, I need to stay with them, stand with them, make sure whatever life we can assure as a doctors, let's say, will be beautiful, will be a celebration, no? And so, I never studied in my career, I mean, in the very beginning, palliative care, but I realized I got to palliative care before even studying palliative care as part of the medical care.
Well, I think that's beautiful. I loved what you said, to not censor the desire to save. That was really beautiful. I think that sometimes people have in their minds what palliative care is or what hospice care is. Maybe let's do some definitions, Dr. P. Like, what is the definition of palliative care? Is it the same as hospice? Are they different? So maybe walk people through what it actually is.
So palliative care is people always think about end of life. It's not just that. Palliative care is a medical and nursing care, actually multidisciplinary care, who takes care of patient with very complex condition, including a condition that would lead to the end. And so should start with any patient who has a very, very complex condition with potential adverse outcome, but not necessarily, to support the patient, support the family, and make sure that that journey is a celebration of life. Now, because the patient have a complex condition, severe condition, and sometimes the outcome is the end of life. End of life is also part of it, and actually it requires a lot of care support to make sure that the patient is comfortable. But it's not necessarily just end of life care. In fact, it should start much earlier. And I have to say that in all these years that I'm running this program, Columbia University, I have patients who lived for years treated with palliative care. Palliative care also is a care which takes care of the fundamental needs of the person. And, I can tell you about babies, obviously, because it's my job, which is the need to bond with the family, to be welcome and celebrated in the family, the needs to eat, because babies love to eat, and we like to feed our patients to respect the natural course of life. We are not there checking calories and make sure that there is a growth curve adequate. We feed the baby because baby is happy to have their tummy full. And then pain management as well. Many of these children, they actually not in acute pain. They maybe needs to be suctioned. They need to be repositioned. They need to get some medication for the cough or something. And so that's also very, very, very important. And so, as I said, there are babies that I follow in my program of palliative care who last 3 minutes, and some of them years. So you follow life and its development.
How do you do palliative care when, like I know you said, when it's minutes or hours, obviously the baby and the family are in the hospital? How does palliative care look like if that baby is living longer, like you said, maybe a year longer? How do you do palliative care when they're not in the hospital?
So the first scenario is when, let's say, a baby is born with a very, very severe life-limiting condition. We know that life will be very short. We prepare everything ahead with the family. We make sure, because the time is so short, is so limited, we need to concentrate the love for the family for this baby in really short time. And so we ask them which are the things that they really want to do with the baby. The vast majority of family come out with a religious background, and we offer baptism, we offer other religious ceremony according to their religion of belonging. You can really imagine as many as people, I would say the vast majority refer to a belonging, refer to the fact that God is in our society present. And then how to introduce this baby to the rest of the family, to the siblings, to the grandparents, if they want to have a gift, clothing, or they want to play music or have a banner or have a birthday cake. So we want to make sure we are ready for that moment, because we know that life will be very, very short. Now, in other cases, maybe the child or the baby has a very, very severe condition, but not necessarily limited in time for survival. And so we don't want to admit those babies to the NICU, where they're going to be separated by the parents. We keep those babies in postpartum with the mom, dad, and other family members if they want to come, with certain limits, of course, because we are in the hospital. And we go, we doctors and nurses, we go to the bedside to make sure the baby is comfortable, the baby wants to eat. Should I do something? Should I suction the baby? Should I give some milk? How do we give some milk? Because some of these babies are so weak, they cannot just breastfeed or bottle feed. So we use a little tube, we use a droppers, or different. We become creative with our speech pathologist as well. And so eventually, let's say this baby survives the mom admissions in the hospital, we get organized with hospice agency in the territory where the family lives, and we refer to them, so then the baby can go home with the family, and then the nurse and the doctors of the palliative care agency close by local can go and spend time with them, and especially be present when the last moment comes. And, and there are rare cases where I send home a child who actually did need any support, let's say, from the hospice for years, up to the point when he or she became really sick. So you never know. We have so many surprises.
Right. Well, babies come into the world when they decide to. If only we could give them a clock and they leave, when it's their time. So I think that I love that you give honor to when the baby will be in the hospital or if they're leaving the hospital, and also honoring families and that journey, because I'm sure that there's no one case that's the same. They're all unique. Those babies are unique. Those families are unique. And I love that you serve them wherever they may be on that spectrum of in the hospital or out of the hospital. What do you think are some of the biggest, Dr. P, like some of the biggest misconceptions or biggest myths that people have about palliative care or hospice care? I'm thinking of sometimes we hear hospice care, we hear that care, and we think, oh, you have to be super old for that to happen to you. But I know that there must be some other myths or misconceptions that people hear and you're like, actually, that's not the way that we do it. I know you touched on one about you're still continuing to medicate, still continuing to feed babies, but I'm curious what some of the others may be.
Sure. A easy misconception I think I touched upon already a little bit is that the palliative care is for end of life care. So
Mm,
when the patient is dying, let's say, someone should come and do something and maybe give a big dose of morphine just to make the patient.
right.
And it's not that. I mean, of course, pain management is very important, but it's more a journey with the patient and with the family. And I think this works also for adults, no? To get prepared to that moment. And that moment can come, as I said, in few minutes, in days, weeks, months, even here. And so is a journey. That's why it's multidisciplinary, because yes, there is a need of a doctor who assess the patient, make sure the patient is comfortable. He can eat certain things. It should be warm and clean. You need a nurse, you need a social worker to help the family organize things that need to be organized. You need a chaplain for, to make sure that this family is also accompanied in their belief. And you need psychologists sometimes because the situation is tough. I don't want to make this like easy, no?
Right.
To lose a child or to be in the position that you're gonna lose a child is a huge wound, and stays through the life, no? But in the same time, we want to give support because we want that the family understand, first of all, that before death there is life. And so the role of palliative care is to live fully life now, okay? Without being concentrated on what is going to happen. We will happen, but right now life is here. No? So that's also very, very important. And eventually, when the child passes or the person passes, you need to continue to support the family. We do in our program, we have a bereavement follow-up program to continue to talk with these families. For families, it's very difficult to talk about what happened with the neighbor, the rest of the family, because people, they don't know what to say. Instead, with us, we live that moment with them when the baby was around. And so it's so much easier and simple. And we can also give psychological support exactly to face this very, very, very acute wound that, they need to stay embraced, through the life sometimes. Yeah.
Well, I know that y'all have a unique program at Columbia, and we're going to talk about that in a minute. But I'm curious, Dr. P, what's the majority of hospitals? How are they approaching palliative care for babies and neonates? Like, what's the, I guess, the standard of care when it comes to palliative care in the vast majority of hospitals around the country?
So, I mean, palliative care for adults has been around since, for years, as you know, since Cicely Sanders, the doctor from England, started and then developed all over the world. Pediatric palliative care also developed many years ago, I would say, and is spreading. Neonatal palliative care or comfort care is much less present in terms of services on people that work on that. And is basically run by together obstetrician, neonatologist, and nurses involved in those two fields, because it happened most of the time within the admission of the mom in the hospital. For many, many babies, they die just before being born or afterwards. The number of babies who get to go home are like maybe 10% of those babies.
Wow.
And so I have to say that this discipline started again several years ago. I think that the year when really was published in medical literature was 1997. There was a publication called Perinatal Hospice. And after that, a number of doctors, either gynecologists or neonatologists or nurses as well, start doing little programs or referral, etc. Right now, there is a website which is called perinatalhospice.org, which I think is the largest, more comprehensive internationally, not just in the United States, but internationally, where they're listed the number of services, programs, or people available to run programs like this or give this service. And we have about, let's say, around 300 in the United States. And but not all these programs are comprehensive, meaning starting meeting the family during the journey in pregnancy at the moment of diagnosis, accompany them, welcome the baby at birth, following the baby, stay with the family along the life, basically, which to me is the ideal of how this service should be given, because it's really a journey, the perinatal journey together with the family. And so in some centers, maybe there is a nurse who help mom when she comes to deliver. In other, there is maybe a doctor, in other a social worker. But I really, myself and my team, we are really actually very, very strong on the fact that we want to we are developing education and training to help the hospital have this possibility, because it's something that happens more often than what people know.
Well, let's talk about that, because I think your program is unique. So I want you to share with people what it is that you do, but also how you're trying to help other hospitals do the same thing.
Sure. So again, I start my program just because I was involved in the care of many mothers expecting babies with life-limiting condition. And so again, I started on my own, following those women and being present in the delivery room when the baby was born, and then meeting them in postpartum. Now, this was a huge step to keep the baby with mommy in postpartum. That was really huge. And I spent days there with the nurse who was terrified having in a wet baby nursery a mom with the baby dying, which, I get it, but there was not much to do if not to embrace the baby and the mommy and stay with them, in a sense. It's not intensive care that we provide. Then in my hospital, a nurse loved what I was doing, so she started volunteering with me. And over the course of time, I was fortunate enough to receive some donation from foundations. And so I was able to open a position for a nurse and then for a social worker, et cetera, et cetera. And right now we have a nurse midwife, and a nurse, a social worker, a manager. So we are really structured. Now, last year we had also a young neonatologist working with me. So it's two of us. We can really cover 24/7. And we work very well. In a number of cases, it's becoming like logarithmically high. I have to say that we started in 2008 meeting 13 families. And last year we are counting, this day we're counting encounters for publication. We had more than 800 encounters with many families, because the program is dedicated to those families. And so, as you can imagine, even during pregnancy and then afterwards, there are many needs to encounter and clarification, support, and etc. And so, but the effort, our vision to spread this approach all over the world as is key point in a training that we do every year. We have been doing for several years now, and we do in New York City at my hospital, Columbia University. This year is going to be September 18 to 20, and is 3 days intensive training for doctors, nurses, and social workers from obstetrics and gynecology and neonatology. And is very much teaching, but also a lot of hands-on training, really. We do a lot of video simulation because it's something new. Even there is a big difference from palliative care in the adults and in children, and this one in babies. There are two different kingdoms.
Yes.
Yeah.
Well, I love that it sort of happened organically. It sounds like it was a love that you had, and someone else saw the love and the care that you were providing to those patients. And then now other people are saying, we're onto something here, that this journey, as we call it. I loved how you said that there is life and then there is death, but we don't want death to encroach on the life. Like, we should have the opportunity to appreciate it while it's here. And I love that you're giving people really excellent tools so that they can serve their patients better. I'm curious, Dr. P, when you talk about palliative care for neonates, what is it that makes it different from pediatrics? Is it the shortness of the stay? Is it because it's at the very beginning, as opposed to a child who's maybe has a life-limiting or a life-altering diagnosis later on in life? Like, what makes palliative care for neonates so unique in your mind as opposed to the others for pediatrics?
Sure. In pediatrics, for the little that I know, a child will go to palliative care after he suffered from cancer, leukemia or any kind of cancer. So he's a very, very, very sick child who is basically facing the end of life. So those patients are extremely sick. They have a lot of pain, and so they have specific needs, especially connected with pain management. Okay. The vast majority of babies who require palliative care are born with severe conditions which are not necessarily painful. A baby who is born with a condition called anencephaly, for example, so the skull is not formed and the brain remains very little, they basically can be born and sleep all the time, or maybe cry, or not necessarily feel pain, or a baby with no kidneys, or then some genetic severe conditions. And so our population is more a population of babies. They need to be held, they need to be fed, they need to be kept warm. And yes, some of them, they can have some sort of pain and distress with breathing and everything, especially when the end comes. But we can actually manage the vast majority of them with no IVs. We give intranasal fentanyl, oral morphine. We can and sometimes we just manage them being held and do colostrum care, put some mom's milk on their lips. Mm-hmm. So it's a very, very, very different kind of discipline. And also a child who lived in the family for a certain period of time and then became sick, and then the family has a story already with the child. With our patient, yes, there is a story, which is beginning of a story, which is the pregnancy, especially for the mom, is very intense. Mm-hmm. But for the father, for the rest of the family, we build a story with them. Mm. They need to know this baby. They need to take pictures. They need to look, looks like grandmother or grandfather, and so it's very intense, collecting memories and spending time 24/7 with the little baby, which most of the time is really not in pain.
I'm curious, Dr. P, when someone is referred to you for palliative care, can you walk us through what the process is like of meeting them where they are and then determining. I know you were talking about some of the things that some families decide to do to celebrate life depending upon how long that you think that they may have with their child. So what happens when someone's referred to you, and then what does that look like from the time that they're referred until the time that their baby's no longer with them?
So we meet families in pregnancy. Obviously, at a certain point, they receive a diagnosis of life-limiting condition, and our obstetrician basically call us in. Sometimes we talk to them along with the obstetrician, sometimes on our own, and it's going to be me as a physician, my nurse, my social worker, and we basically start a conversation with the family saying, we know you heard like a very, very hard diagnosis about your baby. So we make them talk. We want to hear from them how much they understood and which kind of question they have. And one very, very important point is to let them talk and share with us the fear, the hopes, anything that they carry within their heart regarding that baby. We also, on my side, I go through the medical expectation for that baby. And, despite how sharp and secure is the diagnosis, I always give scenarios.
Oh, that's good.
Because we don't know. Babies with the same disease can live 1 day or 10 days or 3 months. And so I give them an idea of how the baby will look like when it's born. Very often they hear, when they receive the diagnosis through ultrasound, they hear names like absent nasal bone or banana sign, like description of the body of the baby, which means something to fellows and attending physician and doctors, but for the family is terrifying, especially the absent nasal bone, which is actually a sign, could be a sign of a condition, but it doesn't mean that the baby has no nose. And so I always underline that. We will tell them how the baby will look like. We can show pictures of other babies with the same condition when they're born and describe how the baby will behave and give them worst scenario, best scenario, everything in the middle. And then in the conversation with them, try to understand what is even very, very important to them. If there are things they would not give up. For the management in the delivery room, also some vast majority of parents, they dream to take the baby home. Some of them are afraid and they would rather keep the baby in a pediatric rehabilitation than go spend time with the baby there, just because maybe is a child that will have a short life but needs to be managed a lot from the point of view of suction, oxygen, or things like this. And so we try to make plans. Now, it doesn't happen only in one visit.
Sure.
It can happen, we start talking there and then again, and again. My nurse and social worker, they address other plans. For example, what to bring to the delivery room, which religious rite they want to celebrate with the baby, which kind of memories they want. Vast majority of parents, they want a lot of memories, pictures, tridimensional cast. Some parents, they say, I don't know, I want to wait when the baby is born. So we try to respect whatever is their desire. We give as a gift to all of them a book which is called A Gift of Time by Amy Kubelbeck, because that book to me is very, very important. It is a collection of witnesses from families who went through the same thing. And so it is pretty much unique. And so we give to them as a gift. Then the moment of delivery comes. And so we try to be there all together. Now I work in a big institution and babies come when they want. So good news is that almost all the time we'll be there, me personally, my team. But it could be that occasionally a mom at 3 a.m. comes to the hospital and delivers. So is also this a good news because this is a way to mentor our fellows and colleagues, attendings, etc. And so I have to say that over the course of the years, we are pretty much very united, following the plan, which is in the chart, and respecting the desire of the family all the time. Really has been really an institution at this point, our program. But of course, in the morning we arrive and we'll continue the celebration together. And as I mentioned before, if baby makes it outside from the delivery room, then can go to postpartum, and we go there, we'll take care of what needs to be taken care. We celebrate. And then eventually, if the baby makes it, can be transition home or to rehabilitation. It happened a few times. Usually parents really want to have the baby home with them. Yeah.
Yeah. I was actually going to ask you about that. What happens when a baby's born and you're not at the hospital? How do you know that they follow, the wishes of the family? So I'm happy to hear that you have written instructions. The hope is that they follow those, but also that they see the ability to meet someone in their deep grief or maybe on their hardest day, but how can they serve them as a medical professional in a really difficult position? This podcast is produced by Hand to Hold, a national nonprofit, but we're more than simply a podcast. Hand to Hold is here to support your NICU in two ways. One, you can refer your NICU parents to us for support, or two, you can bring dedicated Hand to Hold support to your NICU, either in person or virtually. Our support consists of one-to-one group and educational resources, including our family-focused podcast, NICU Babies Parent Support. For more information, visit handtohold.org and click on NICU Professionals. Dr. P, I'm thinking about patients who maybe they haven't had proper perinatal care, maybe they don't have access to things that maybe whether it's insurance or hospital facilities. How do y'all, I guess, address those patients that may not have some of the privileges that other patients may have when it comes to palliative care?
So, first of all, I mean, in our hospital, we welcome anybody, and because our service is under the umbrella of intensive care unit in our NICU, and so it's the right of any mom and any baby to be welcome there. Personally, there have been a few cases where the insurance doesn't cover the consult with me. We'll do anyway. We just don't charge. I mean, we just leave it like this. And so for us, the key point is really to support the family, to support that baby. And we work the system. We work the system together. We have also very, very good social workers. There are funds that can be used also to help the family. We have possibility to have a taxi to go pick up mom and come to the hospital, helps for the funerals. So we kind of develop a network to be with them no matter what. So I think can be that if we can do it, anybody can do it.
I know that as we talk about end of life issues, or I know you said that some of your patients have either a belonging or religious background and then some don't. How, Dr. P, do you approach each family, each baby, and meet them where they are and then give honor to whatever it is that they desire for the life that they have for their child? I know that that's complicated, but I also know that it's possible, but I'm curious how you really give honor to all those varying ideas about what they should or shouldn't do, or how do we celebrate this or how do we not? How do you give honor to all of that?
Well, this is a very, very important point. In our conversation, as I mentioned a little bit before, we want to know where the family stands from any point of view. Desire and hope for the life of the baby. And of course, everybody wants the baby to live as long as possible.
Of course.
But also where the family stays, there is a father, there is a partner, there is what's the social situation of the family, the religion of the family versus, and as I mentioned before, the vast majority declare to belong to any kind of religion. It's amazing. If you come in our NICU, almost every baby in the crib, they have some religious signs, because I think when you are in front of, life and death, you recognize that there is an above power, whatever it is. But in a specific, we ask them openly, how do you want to celebrate your baby? There are things that are very important to you when the baby is born. And then we go in the specific, are there religious ceremony, are there family ceremony, are what is your siblings, etc. So we open questions in front of them, and then they can fill in anything. We can, in the limits of the possibility, obviously, but the goal is really to make that moment of celebration focus on what is important to the family.
You mentioned siblings in there. I know that you talked about your social worker and how you meet moms and dads and where they may be with their own particular babies and their particular situation. Do y'all have things that address how siblings might be feeling? I know siblings vary in ages, so if you've got younger siblings, they may be completely unaware. They just may know that something's not quite right. And then the older that they are, the more cognizant they are of what's going on. Do y'all do any sort of specific, I guess, emphasis on helping siblings navigate through that process as well?
Sure, we try to start even during pregnancy, because one of the hardest things for family, for parents, is to share with the siblings that there is a baby, but the baby will have a short life, and this is really, really hard. So our social worker and our child life as well are always available if the family wants to mediate that conversation with the siblings according to the age of each child, let's say. They can give a booklet that can read together with the kids. They can bring the kids to the hospital, have a meeting with either a social worker or the child life, talking about life and death, and teach the parents expressions that are very important. For example, never say, "Oh, the baby went to sleep," to say "died," because then the little boy or little girl, they will be terrified to go to sleep because then I'm gonna die, or things
Right.
like this. And so there is an education really strong there in preparation. And then preparation also for the day of the birth of the baby, like prepare gifts, prepare a poetry or a drawing or something. So the whole family participate to the moment of celebration. And it can continue also afterwards as a support for after the loss.
So if there's a hospital, Dr. P, because I know that every hospital addresses if there is a child who has a life limiting or a life altering condition, absolutely. But not all of them have a dedicated neonate palliative care program. What do hospitals do if they don't have that? Do you know like what their approach is to the child? I mean, they may or may not have a social worker around or what have you, but I'm curious if your hospital doesn't have a dedicated program like y'all do, how do they serve those families?
Yeah, that's a very good question. In one side, I think that in neonatology, even in the NICU, we face life and death all the time.
Right.
And so I think a good neonatologist should know the essential elements, rather, of how to have a conversation and how to support a baby and a family in such a condition. Because for children, for adults, the pediatric palliative care doctor is like a figure who comes and support the doctors. No, for us is, I think, yes, a service, a program like ours is important. Is very, very important, because there is a lot of embrace, a lot of multidisciplinary interventions. But I think any neonatologist should be able to have this, as I started myself, to have a conversation talking about what's important to you, to describe how the baby look like, to describe the different scenarios, and to be present when the baby is born, helping make the baby comfortable, and the family bonding with the baby. So I think it's part of our duty. I noticed, though, in the past, at this point, several years, we have a lot of people registered coming to our training in New York because there is a need to know more about like which kind of expression using and see really how to manage the family in a proper way. But I think it's part of our job in the very end to just to stand with the parent when you can heal the baby and celebrate the baby's going home, it's healthy, that's it, great.
Right.
Or when things they don't go this way, but is a need of teaching, learning, and to also, I mean, I always say when my lessons that we do care. If you care for a patient, something good will come out for sure. You start with your heart, and something good will come out.
Well, I'm curious. There are no guarantees in the neonatal intensive care unit. Our hope is that those babies go home and that they thrive, but sometimes everybody doesn't get their happy ending. I'm curious, Dr. P, how, particularly for y'all who are dealing with patients who primarily are having to say goodbye to their babies at some point, how do you manage the grief on your side so that you can continue to be a resource for those families?
Well, being a neonatologist also, so I have a double hat here.
Yes, you do. Oh, that's sweet. Yes.
I have very beautiful and successful stories as well. So I think this is very helpful because I see the two possibilities.
Mm-hmm.
The other thing is with my team, we are really together, also taking care of each other. We also debrief about what happened or prepare for what is going to happen. We have a moment of celebration among us about things in our life, our birthday, or my social worker, the baby's born or something. And so to be in a team, I think helps very much to support each other, really. So the teamwork is, I think, fundamental. Yeah.
Yeah, I often think, I know that sometimes we like to think that it ends when the life ends, but that's really when the hard work starts, is because then you have to move forward with your life and move with the people that are no longer with you. So I'm curious, Dr. Pete, how do you work with patients once their baby has passed away? I know you mentioned that you do some follow-up. I'm curious what that looks like.
Sure. We have two different services. One is basically one-to-one with the mom or both parents, and we'll continue with the schedule that is really a proposed schedule, but also is up to the family how often they want to see my nurse and my social worker, sometimes the psychologist, and it continues for sure for a year, and then if necessary, we'll go even further one. Then there is another service that we offer and started during COVID because it was impossible to meet in person. So my nurse, social worker, and psychologist, they start meeting via Zoom, meeting the whole family, I mean the parents.
Right.
And this is once a month. And it continued to be like that also because people, so mom wants also dad to be there. And if they come to the hospital, then nobody takes care of the kids. And then the parking is so expensive, etc. And so they do this monthly conversation, let's say, with the families. And it's amazing that families who just lost a baby, for example, are very much supported other families for which happened 3 years ago, and so they can talk about their journey. And my nurse, social worker, and psychologist, they kind of moderate and help the conversation to go in the right direction. And we have parents that comes for years to that, so I think is useful.
Well, nobody really knows what it's like unless you've been there, and so I'm sure that having someone who sometimes you don't have to say anything because they just understand, and I think there's a lot of comfort in just the presence. I'm sure that those families find a great source of strength from that. So if there's a hospital, Dr. P, that says, okay, we either need to do a better job or we want to have components of what y'all do in your own program there at Columbia, how does a hospital go about getting dedicated neonatal palliative care and that team that you talked about in their own hospital?
So first of all, I would say they need the training. And so they can come to our training, which is done once a year, Columbia in fall, in September. Second, our team is also available to go locally to do 1 day training intensive, like 8 hours with the essential, and we'll go there. And we can also stay in touch, to kind of mentoring them. It needs to start from champions. So person to person, 3 person who feel that this is something that we want to do. I don't think it's going to happen that the administration says we need to do this, but nobody's really willing to do it, like everything else in life. They need to find a champion, at least one, who starts, and then everybody else follows. And it's interesting that everybody else follows afterwards, because when you see this done, is such a jump up in your professionality. For example, I saw with the nurses in postpartum, at the beginning they're terrorized. Then we do have the NICU nurses going to the bedside of mom. Also, some of the nurses in the World Baby Nursery, which usually take care only of mom, they become interested. They see how beautiful it is, how your professionality can increase, and so can spread very quickly. But I would say teaching, mentoring, and champions.
That's how all good things happen, is somebody's passion takes
Yeah.
over and you're so pulled in by the passion in which they can serve their patients that you can't help but want to be a part of it. That's a good point. It does just take one person, I think. That's a good reminder. You mentioned earlier about phrases not to use. So what, Dr. P, would be some phrases maybe not to use, or phrases that you should use with a family that's in a palliative care situation? What should you say? What should you not say?
So there are different fields. For sure, during the prenatal consult, I never use the word fetus when we talk about the baby, because every woman, whatever religion, race, social, when they discover to be pregnant, they say, I'm expecting a baby, right? And so we take cues from the family in our conversation, because we
Sure.
want to make everybody at ease. But and so I also found myself always making also the family at ease, talk about their baby. And in fact, we always ask, is a boy, is a girl? Do you have a name for your baby? And I love that, because then we call that baby with a name, and and you know how many times, although I tell them, bad news for what concerns the survival of the baby, they tell us, no one gives so much hope as you guys. And I think this is connected with the fact that we talk about that baby being alive now, who is a reality, but the life is now. After birth, we'll see, but still now this baby is there. Another thing that I think is very important is to clarify with the family that they are destroyed by the bad news, but the baby inside has no idea. The baby inside feels very good, because the mom is giving oxygen, nutrition, everything. Baby doesn't feel any pain as long as it's mommy belly, and he has no idea. And so to reassure them, the life of this baby right now is beautiful, and to concentrate, focus on that, enjoying at least the pregnancy. And I think this is very, very important. Then after the baby's born, things that you should never say, unfortunately, it comes out. Forget about this, you will have a new baby.
Mm.
Don't think about, or don't get attached, or things like this. Because, as soon as you become pregnant, you are attached. This is your baby. And this is true for mom and also for fathers. And so we always say the attachment is already there. So let's face it, you love that baby, and that's great. That's good. No, so I think you want to avoid, try to forget about something that will never be forgotten. And the family will feel very isolated because they don't really understand what they go through.
Right. I think it's important that we honor where people are. Sometimes it's easy to look at a certain situation and think how we might react, but giving honor to how that particular family is processing that and then how they're moving through it, I think is a good reminder to all of us, not just medical professionals, but people who love friends and family who may be going through something like that. It's important to be present and just let them know that you're there. I think that's good advice. I'm curious, Dr. P, with your program, what do you think is I guess, a hallmark of an excellent palliative care program for neonates? Like, are there certain things that you say, these things, when put in place, make an excellent palliative care program that honors the life of that baby, but also the family that loves that baby?
So, first of all, family needs to be to feel embraced, because if there is only one person in the hospital who runs the show or a group of them, they need to understand that we are there to serve them and that baby, and therefore accompany the family through the whole journey and make sure that we are the people for staying with you. We call continuity care. So then I meet them during pregnancy, I meet when the baby is born, and we meet also afterwards. Then to prepare the environment to welcome that baby. So again, communication in the chart should be written what the family wants, desires. Debrief before, when you know that mom is coming to deliver, make sure everybody knows. Prepare a private environment, for example, for postpartum, so then the family can have privacy, and make sure that we fulfill all the desire of the family, and then continue to follow them afterwards in time. To do all of this, it doesn't require necessarily a big service or program, a couple of people can do it, and I'm sure it's happening already in this way in many, many institutions. Yeah.
Yeah. I'm curious. I always love when I ask you to dream a little bit or give advice, Dr. P. What would be your best advice to a nurse who is taking care of a patient and their family, who that baby has a life-limiting condition and may have days or weeks to live? What would your best advice be so that that nurse can serve that patient and their family in the best way possible?
So I would say, look at the baby for who the baby is, a beautiful, cute little baby, and make sure to facilitate that mom can bond, mom and dad and the family can bond with that baby, and treat the baby like any other baby. Basically, try to feed the baby, try to make sure that the family will enjoy also by feeding the baby, make sure the baby is not in pain. But that baby is not like a strange entity or something. Is the baby part of the story of that family? And so just be relaxed in a sense, smile and talk to the baby, and make sure this moment of intense love will happen, which is also professionally great for us, because we do an intervention that helps that baby and that family.
Well, what you do is good, beautiful, sacred work, Dr. P. So I appreciate it. I know that you mentioned a couple of resources. I was writing them down as you were talking. So the perinatalhospice.org, you said, is one resource. If people want to know a little bit more about your program, a little bit more about that training, or about resources that are available, where should they go to find that information?
Sure, they can go to our website, which is called neonatalcomfortcare.com, And we have information about the upcoming training. We have information about our guidelines. There are little videos with interview with parents who went through care with us, written stories from the families. They can know my team. So there is a lot of, and there is also a nice tab to click with donate, because I reminded that my team salaries is totally independent financially from the hospital. We live out of donations. And so any gift is welcome as well.
Wonderful. And then we'll make sure, just so that everyone is, maybe if they're scrambling to write all that down, it's all going to be in the show notes for them. But Dr. P, thank you for this really, I believe, really important work that you're doing, meeting families in the most difficult place and giving honor to that instead of just saying, good luck or worst case scenario being completely absent. So I think that it's good and holy work. And I think that there are some hospitals that maybe they're doing something and maybe they can do it better. And I love that you have a model for that. So we'll make sure that people can get connected to you and to all those resources. But thank you so much for all your wisdom and insight today. I know it's going to be a gift to people listening. Thanks, y'all, so much for listening. That was a fantastic conversation. I hope that you'll do me a favor. If you love today's episode, please share it with a friend. You can also review over on Apple Podcast or Spotify or wherever it is that you listen to podcasts. You can also give us a listen and a watch over on YouTube. It's how we reach more NICU professionals. Today's podcast episode is sponsored by Reckitt Mead Johnson, whose mission is to nourish the world's children for the best start in life. For more than a century, they have led the way in developing safe, high-quality, innovative nutrition products and continue to push the boundaries of nutritional knowledge with consistent, strong investments in scientific exploration.